Good morning, and thank you everyone for joining us today for the State of ASCs Today, Implications for Hospitals and Health Systems. Your moderator today will be Matt Kilton, an Associate Principal at ECG, who will be moderating your session. The ambulatory surgery center landscape continues to rapidly evolve, driven by market and legislative forces, patients, payers, and providers. Health systems and hospitals are under pressure from all sides to reduce costs, while changes in government regulations and commercial payer practices reward providers for migrating high acuity surgery to the ASC setting. This migration poses a financial threat to health systems given the significance of surgical revenue. These combined factors motivate the demand for ASCs and the need for hospitals to develop and implement a comprehensive ASC strategy. In today's webinar, we will discuss the current state of the ASC market, how migration is affecting hospitals' strategic options, and how hospitals can engage in proactive strategies to survive and thrive in the changing surgical environment.
Thank you. Before we begin the formal presentation, let's go over a few details about the webinar. It is 60 minutes in length, and the first 45 minutes of the program will be a presentation, followed by a 10-minute question and answer session. Everyone should have received a copy of the session handout, but if you were a late registrant, you can download the handout in the handout pane on your screen. Please note that attendees are participating in listen-only mode, but if you have a question, you can type them into the question pane located in the toolbar on the right of your screen at any time. We will be launching an audience polling question during today's program. We hope that you'll participate in this interactive measurement tool. At the end of the formal presentation, we will answer as many of your questions as possible. Finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is very important to us, so please take a moment or two to complete this survey. For each completed survey, ECG will make a donation of $5 to Doctors Without Borders. And now I'd like to introduce today's speakers. Naya Kehayes, a principal at ECG, has devoted her career to working with ambulatory surgery centers and other surgical practices. As the head of ECG's ambulatory surgery practice, Naya serves as a trusted advisor to ambulatory surgery center leaders at a time when patient care is increasingly shifting to the outpatient setting. Naya has provided direction to a number of national health organizations on the issues of managed care contracting, integration of ASCs into health systems, and the revenue implications associated with evolving payment systems and structures. She's an industry leader serving on several national and state boards for ambulatory surgery. Naya, welcome.
Thanks, Matt. It's a pleasure to be here today.
Also with us today is Sean Hartzell, an associate principal at ECG. Sean joined ECG in 2007, and during his time with the firm has focused on helping organizations achieve successful hospital physician acquisitions, implement strategic planning initiatives, and develop orthopedic service lines. Sean has worked extensively on physician compensation plan design and implementation, and physician compensation fair market value analysis. Sean is also a thought leader for ECG. Welcome, Sean.
Thanks, Matt. Great to be here.
We have a lot to cover today, so I'm going to turn the program over to our speaker, Naya.
Thank you, Matt. Today I'm going to start with the agenda. We are going to be reviewing surgery migration, trends and payment implications, current environment and trends. Then we're going to go over some case studies and talk about what this all means. What are the implications to hospitals and ASCs? Then we'll conclude our program with questions and answers. Before I get started with the program today, I'm going to ask Matt to launch an audience polling question.
Thanks, Naya. Audience, you should now see the polling question appearing on your screen, and the question reads, how familiar is your organization with the recent CMS rulings on orthopedic and cardiac procedures site of service modifications? Please select all of the following responses that apply. Not at all, not familiar at all, some familiarity, we have a team of individuals reviewing them, or we learned about it when our doctors visited us. Hopefully you've had a chance to review those answers. Again, the question, how familiar is your organization with the recent CMS rulings on orthopedic and cardiac procedure site of service modifications? And again, please select all that apply. Not familiar at all, some familiarity. We have a team of individuals reviewing them, or we learned about it when our doctors visited us. So let's share the results. Again, how familiar is your organization with the recent CMS rulings on orthopedic and cardiac procedures? 22% of our respondents indicated not familiar. 54% indicated some familiarity. 34% have a team of individuals reviewing them, and fortunately, no one learned of it through doctors who visited us. So Naya, go ahead and, if you will, share your thoughts on those responses.
Well, this is very interesting, and I think that today's seminar is truly going to provide some insights and a lot of information that will help educate the audience about the implications of these changes that are going on with CMS. So now we're going to go back to the presentation. Let's talk about surgery migration and trends. Site of service and surgery migration are key drivers reducing the total cost of care. This presentation slide demonstrates the process of how surgery migrates from inpatient to ASC relative to the CMS rules and regulations, and then also with respect to commercial payers. The surgical CPT codes are typically on inpatient-only lists first, then they will migrate over to the hospital outpatient department list, and then CMS will approve them for the ASC list. The process for moving from HOPD to ASC typically takes 2 years. That's been the standard historical trend with respect to the migration of the CPT codes relative to the surgery on the allowed list. Some of the largest growth opportunities for ASCs have been total joints, laminectomies, HDFs, lumbar fusions, lap hernias, lap cholecystectomies, hysterectomies, and cochlear implants. These cases represent a significant risk for hospitals with respect to cannibalization and will have meaningful financial implications and already are having financial implications. Advances in clinical technologies are allowing smaller incisions and shorter stays, which are enabling these higher acuity cases to be performed safely in the ASC setting. So even if they are not allowed by CMS on the ASC list, that does not prevent the commercial payer from allowing them to be performed in the ASC setting. Some of the other surgeries that are on the lower half of this slide, endoscopy, ACL, shoulder repairs, sinus surgery, retina, and lithotripsy, are surgeries that have been moving and migrating over time and have represented a significant growth, continued growth opportunity for ASCs. Moving on to the next slide, number 7. In 2020, the Medicare rule changes, which recently came out, have significant implications for both hospitals and ASCs. I want to go back to 2018 for a moment to talk about TKA. In 2018, total knee arthroplasty, 27447, was originally removed from the inpatient-only list and then moved to the HOPD list, the hospital outpatient list. Now, 2 years later, total knee arthroplasty has been approved for the ASC list, again, following the trend we just discussed. The reimbursement rate for ASCs based upon national CMS on the most recent publication is $8,609. In addition, it's important to note that CMS removed total hip arthroplasty, 27130, and several spine procedures that are actually very large procedures. Some of them are fusions from the inpatient-only list and added these to the HOPD approved list. So if the trends continue to follow, we would expect those codes to also be approved by CMS for the ASC setting in about 2 years. The second point I want to talk about with respect to the rule changes are payment for non-opioid pain management. Typically, surgery centers do not get paid separate and distinct reimbursement for drugs. But last year, CMS approved separate and distinct payment for non-opioid pain management drugs that function as a supply with separately to ASCs. This was not approved change for HOPDs, only for ASCs. Currently, the only drug that applies to this rule is Exparol, which is billed under C9290. This is a long-lasting drug that typically provides non-opioid post-operative pain management for up to 72 hours. So, there's potential that, surgeons who are looking to move bigger cases may have more opportunity with having an option for longer-term post-op pain management. In addition, last year, in 2019, the ASC rate calculation was based upon an inflation update historically on the CPIU. ASCs successfully were moved to the same inflation update based upon the hospital market basket as HOPDs. So now we are on the same inflation update. It continues to be the case in 2020. And overall, both hospital outpatient departments and ASCs got a 3.0% increase, with ASCs being maintained on the hospital market basket. Finally, last year, I want to start out with in 2019, there were numerous cardiac catheterization codes that were approved for the ASC setting and historically had only been on the HOPD list. CMS in 2020 expands access further in cardiology by adding 3 additional coronary intervention codes to the ASC list, including 92920, 92928, and C9600. Now moving on to slide 8. What does all this mean when we start seeing these changes in the rules? There's a major domino fall with total knee arthroplasty going to the ASC list with Medicare. The majority of total knee arthroplasty cases are performed on Medicare patients. So this is a significant milestone with respect to approving TKA for ASCs by Medicare. As we had just stated, the TKA reimbursement on a national basis is $8,609. That would be subject to area adjustments based upon geography. Now, the question of whether or not ASCs can perform total knee arthroplasties at $8,609 is highly dependent upon the cost structure and has a lot of implications relative to implants and so forth. However, if an ASC can perform all total knee arthroplasties, including commercial patients, it may very well make sense for them to do the Medicare patients as well, so that a physician can fill their day and do all their total knee arthroplasties in the schedule in one day. The total differential between ASC and hospital reimbursement represents a $1.5 billion savings opportunity for Medicare when you look at the difference in both the inpatient and the HOPD reimbursement rates compared to the proposed ASC rate. At just a 10 to 30% shift in migration from ASCs, from hospitals to ASCs, hospitals stand to lose $625 million to $1.8 billion in revenue from the potential shift of these cases. I think it's an important observation to note when you look on the right of the slide. On the inpatient change in reimbursement is only $181, which is less than a 2% increase on hospital DRG reimbursement for TKA. On the HOPD increase, it's 11%. So again, supporting migration to the outpatient setting. Now moving on to slide 9. This slide just points out that it's not just about TKA. There are actually numerous other total joint procedures in large reconstructive surgeries that are already allowed in the ASC setting. When you look on the far right, you will see the differential between the ASC Medicare rate and the HOPD rate, which is not the standard average. In most cases, an HOPD rate is approximately 95% more, or the ASC is half of a HOPD rate. But because these are device-intensive codes, ASCs actually get a higher payment rate, so it closes the gap between the ASC and the HOPD payment rate. So moving on to slide 10. This is an example of what the potential opportunity could be of TKA migration. And what's the value? What's the value to an ASC? What's the value to a payer? What's the value to the consumer with respect to savings? You know, if you were to assume an average reimbursement rate on a commercial payer for total knee arthroplasty of $15,000 to $23,000 a case. Some payers may pay the implant separately and some may include it, and this is just an example. And there were 300 new total knee arthroplasties with commercial payers that could move into an ASC. This represents 4.5 to 6.9 million plus in additional commercial revenue to the ASC. What does this represent in savings to the payer when you look at the scenario on the right-hand side, where that same total knee arthroplasty may be reimbursed at $28,000 to $35,000 in a hospital or more? You know, that cost to the payer is 8.4 to 10.5 million. So the savings to the payer in this example is 1.5 to $6 million. If the consumer, the patient, has a 20% coinsurance, that represents 300 to 1.2 million. It does not take a lot of cases to create incredible value with surgery migration of total knee arthroplasty. And if you can fill the whole day, now that Medicare has approved it, that provides more opportunity for the surgeon to move more cases. So let's move on to slide 11. Slide 11 reflects the next domino that we talked about earlier on the rule changes relative to cardiology. Several years ago, in the top portion of the slide, you'll see numerous cardiology surgery codes that have historically been on the ASC approved list. Many of these are pacemaker codes and generators and things like that. Now, starting in 2019 and moving into 2020, cardiac catheterization and coronary intervention codes have been approved for the ASC, which just, again, enables the ASC to provide more comprehensive services in the cardiology space. These are material potential for savings between the hospital and the ASC setting to Medicare. When we looked at HOPD to ASC overall, on the initial proposed rule, the differential between HOPD to ASC was about $500 billion. So again, you know, if these procedures start moving to the ASC setting, that represents a potential for meaningful savings to CMS and additional risk and loss to hospitals. Well, let's move on to slide 12. So what does all this mean? What's going on with payers and employer groups and site of service with respect to migration? Self-insured employer groups and payers are developing benefit designs, and they're implementing aggressive policies that drive surgery to ASCs and other outpatient settings to reduce the total cost of care and out-of-pocket spend. Payers and employer groups are establishing benefit designs that limit copays and coinsurances when surgery is performed in an ASC. It is not uncommon for a payer to call a patient and provide them with insights on lower cost alternatives, i.e. the ASC setting, when it's available for their surgery. There's a lot of education going on. In October 2015, United Healthcare implemented a national policy requiring approval for surgery to be performed in a hospital when an ASC is available. This started out with about 24 surgical codes, and there are some limitations in some states. You'd have to look at that policy on the internet. It started out with about 24 codes that range between cataracts, some urology codes, pain management codes, carpal tunnel, and so forth, and actually in GI endoscopy. And just recently, in November of 2019, United Healthcare implemented a site of service medical necessity review policy for certain musculoskeletal procedures. There are about 65 surgical codes on that list. And again, there are some limitations and modifications depending upon the states, but it's a good policy to go out there and research. It is on the internet. This policy effectively says that you need approval to have these procedures in the hospital setting if an ASC is available. And it provides an overview of ASCs and how to get to them to have these surgical procedures. Again, this could be a significant volume of surgery in the hospital setting that will potentially migrate out of the hospital into the ASC setting. And when you have a national payer like this making these types of policy changes, there are certainly other payers that we would expect to follow suit. Large employer groups are contracting directly with providers to develop bundled payments for the lowest cost setting. So these self-insured employer groups are seeking out providers and facilities that are going to offer the most cost-effective option, and they are redirecting care. And again, ASCs play a major opportunity and role in this process with employer groups that are doing direct contracting. Now I'd like to move on to slide 13. So, we are seeing a lot more hospitals that are considering or entering into joint ventures with ASCs. How does this affect, a health system relative to a conversation or an opportunity with a commercial payer? As hospitals look at measuring their risk and what is the dollar value of migration of these surgeries, the reality is they're going to be left with a lot of surgeries and a lot of patients that are sicker and may be more costly to take care of. So it is very, very important that if a hospital is in a JV, that they are at the table having a conversation with the payer, because they have a significant voice, and that could both help the hospital and the ASC from the standpoint of the conversation about the patients that are left over in the hospital that are sicker versus what's their opportunity, what's their level of support for that migration to the ASC. If there's the opportunity to find that sweet spot, and the hospital can be an active participant in the managed care contracting process, there's potential for a greater opportunity for the hospital to help get a more preferred rate because of the out-migration from the hospital and the opportunity for the payer to save money if the hospital is supporting that migration. In addition, this creates opportunities to enhance value-based alternative methods such as bundled payments, shared savings, and gain sharing by incorporating ASCs into the contractual arrangement with the hospital. With that being said, I would like to now turn it over to Sean Hartzell, who will discuss the current environment and trends.
Thanks, Naya, and thanks everyone for joining the call today. As Naya mentioned, the market is rapidly evolving. We've got government payers, national private payers, employers, physicians, all clamoring and all actually moving in a direction that is really migrating surgeries out from a hospital and health system into a more ambulatory setting. And what we'd like to do over the next few minutes is really just talk a little bit more about some of the current environment, what we're seeing, and then get into a few case studies, and then finish it up with what does all this mean. So why don't we first start with some more of these evolving trends and what we're seeing. So on slide 15, obviously Naya mentioned payment and reimbursement, and that's incredibly important. And really what we're seeing is a lot of organizations innovating around these payments, and ASCs actually present a really nice opportunity for some of these increased incentives that support alignment between hospitals via these payment methods. So when we think about case rates, ASCs have been working in the case rate model for years. They really have to understand both the revenue side of that equation as well as the expense side and every little piece of the puzzle that goes into the expense side. So kind of managing at a case rate and really being able to succeed in a case rate environment is critical for an ASC. And so that's a nice, a nice feather to add to a hospital as far as from that perspective. At the same point in time, understanding your revenue and expenses at a case level really allows us to get into a little bit more of the risk sharing models and really managing payments and that payment risk differently. And finally, that all kind of points to the evolving trend of bundled payments, and the opportunity exists to really leverage ASCs as a site of service within a bundled payment, especially when we're talking about things like total knee, total hip, and other orthopedic services right now. In fact, we're working with an organization that's participating in some of these bundles and is really in the process of bringing to bear and bringing into their system of care ambulatory surgery centers as sites of services to really allow for high quality outcomes and really a different expense base to allow them to get some favorable economics as it relates to the pricing underneath the bundle, excuse me. And so with the payment innovation as the background, if we move over to slide 16, you'll see Naya mentioned 2 dominoes, and I'd like to at least present a third potential domino that may not be falling, but is definitely teetering. And that is the certificate of need or a certificate of public need or any derivative thereof from a nomenclature perspective. There are probably about 35% of ASC surgical centers are located in states requiring certificate of need approval. And as we think about migrating surgery, right? Obviously, whether or not there's a CON in place has some implications around that. And I think in every state where there is a CON law or a COPN law, we are seeing physicians, other groups, really going after and trying to push those laws to the side to allow for a little more of what they would call the free market system to take effect. And I think probably with the exception of Vermont, where there's the CON requirements are so strict, there's only one ASC in the states. Kind of juxtapose that with in Maryland, where there is still a CON, and the CON in Maryland is really for any ASC that has more than 1 OR. So, as such, we see a lot of single OR ASCs populating and promulgating throughout Maryland, which really makes it interesting. So you have basically 2 sides of the coin there, even on the CON piece. And man, we've been probably every state where we're doing work as it relates to ASCs, they're talking about, how do we relax the constraints around CONs? And that really poses a huge, on the one side, a huge challenge, on the other side, an interesting opportunity for hospitals and health systems as they think about moving forward and making sure that orthopedics, cardiology, all these other big specialties, we have a good system in place to really think about migration, and we'll get to a couple examples of that in a few minutes. What I'd like to do is kind of have us move along to slide 17, which really starts to identify some of these opportunities that we have as we think about and as we understand a little bit more about the migration of surgical volumes. And on the left-hand side of this slide, we have things like there are 4 different vectors we like to think about from an opportunities perspective. The patient experience is one of them, right? How do we change patients' view of our organization and our health system as we introduce ambulatory surgery and more ambulatory sites of care for the patient? How do we, right? How do we change how a patient thinks about how they're going to go to a doctor or a surgical event? And that also rolls into how do we design our facilities with efficiency, and thinking about how do we get patients, physicians, staff into the facility and through the facility in such a manner where they have a great experience, but we're also making sure that we are moving as optimally as possible, which really ties into kind of that physician alignment piece. And as we think about a surgery migration and who's doing those surgeries, it's important that we understand the motivations of physicians and how can we align and partner with our physician community in such a way that we are building building a brand and building accretive access points for our hospital, for our health system, which finally rolls into the whole payment innovation that we discussed a few slides ago, but really thinking about using and leveraging that lower cost of care that's found within an ambulatory surgery environment to really help build our ability to innovate from a payment perspective, be it with case rates or risk sharing or bundled payments. And really, as we think about those 4 vectors of opportunities, all of those are really predicated on making sure that we know when those surgeries will move and migrate out of our acute care facility and our hospital outpatient departments into more of an ambulatory setting, and being able to develop plans to address that migration so that we have everything ready to go when we start to see some surgeries migrating, so that we're kind of ahead of the I would say ahead of the wave as opposed to behind the wave. What I'd like to do now is really drill into a few case studies, and really we've got 4 or 5 case studies here that we'll talk about, and really starting on slide 19, where we this is really the start of any sort of engagement, but we recently completed a 5- and 10-year migration assessment for a multi-hospital healthcare organization that and in doing so, we examined DRGs, CPT codes, ICD-9 and 10 codes, ASA levels, length of stay, patient age, payer, et cetera, and ran that through a fairly rigorous methodology to examine and determine the potential of that case migrating from their current location of care, so their current site of care, which would be kind of an inpatient or a hospital outpatient department, into an ambulatory setting. And so what we did is we looked at about 30,000 surgical cases over a 12-month period, and we saw that about 63% of those cases could move and probably will move in the next 5 years, and 67% of those cases will move out within a 10-year time frame. And those numbers sound pretty large when you do the math. What we then did is we broke that down and we looked at just their joint replacement and cardiology cases. And so you can see about 20% of those 30,000 cases were either joint replacement or cardiology. So the two of the main components that Naya identified earlier in the presentation. And we saw that, in the next 10 years, we believe that about 40% of those joint replacement cases will migrate to an ambulatory setting, and almost 60% of the cardiology cases will migrate to an ambulatory setting. So in thinking about that, that really changes the calculus quite dramatically for this organization to really think about how do we grow our ambulatory surgery capacity, and how do we partner with physicians to manage things like orthopedic services and cardiology system-wide, so that we are making sure that we are aligning with our physicians appropriately and constructively. As we move into slide 20, and this is really the next case study, I know we talk about it as mitigating the risk of the inevitable, but I also like to think about this as constructive cannibalization. And so with this client, our client was a community hospital at 15 ORs, and they co-mingled inpatient and outpatient surgery. They also had a designated day surgery unit. They did about 12,000 ASC eligible cases, and most of those cases were done with a large multi-specialty group that was threatening to move its outpatient surgery out of a community hospital. And they were actually a group that had a fairly strong lobbying group at the state capitol trying to reduce or eliminate the CON in the state. Now, the community hospital, had to evaluate the implications of different ASC structures, and obviously there was fear of this group building a large ASC without the hospital, because the competing hospital in the same town also had a hospital ASC joint venture with physicians. And so we actually helped this organization examine multiple potential future states. And slide 21 actually shows us the results of that state, and really strikes into this whole constructive cannibalization. On the left, if we were to build or partner with the other hospital around a 2-room OR JV ASC, our client would lose probably in the $2 to $6 million range. If we were to JV our existing HOPD volume to an ASC, and we're probably in the $6 to $11 million range. And then if we were to obviously convert all of our hospital outpatient areas to a joint venture ASC, we're probably in that $12 to $20 million range. And then if the multi-specialty group goes rogue and the hospital loses all the volume, the hospital is looking at about a $40 million revenue loss. And so, those are pretty stark futures, which really begs the question, right? How do we constructively cannibalize our volume and still, share in some of the resulting revenue and margin? Because we obviously don't want the nuclear option on the right-hand side to happen. So, right, it's just really how do we understand those potential futures and make a determination as far as which way do we want to go? And kind of, I would say, juxtapose that with the example that we have starting on slide 22, which really, there is some benefits to size and scope. And we actually worked with a large system to develop a statewide ASC strategy through either strategic acquisitions or de novo centers. And really, we helped them identify a series of 5-year objectives. Obviously, we want the whole physician alignment piece. We want to provide access to new revenue for ASCs. We obviously want to enhance our alignment with new and existing physicians. We want to evaluate alternative structures to enhance the equity position as we expect the site of service shift to increase over time, i.e. going back to our first example, and obviously optimize the opportunity for shared savings and alternate pricing strategies. So, right, as we worked with this system through all of these objectives, it was pretty important that, we can open up a bunch of ASCs in all these different areas, but we also needed to figure out how we manage these systems and kind of who does what. And so on slide 23, what we did is we actually helped the organization walk them through a series of decisions around how do we think about developing this ASC network. And what we did is we walked them through 3 different scenarios. One was building their own system-wide ASC management company. One was just providing each ASC with some management support and really making it an a la carte service. And then finally, also thinking about, should we bring in an ASC management company? And we help them think about there's a time component, speed to market versus equity opportunity versus who is actually going to provide the service and make sure that the services are being upheld to the highest standard. So in walking them through this process, we actually identified short-term and long-term goals and helped them kind of start to build that kind of the management support and moving that into a management company. And so, on the surface, right, we're talking about kind of the back-end management functions, but what actually happened because of this is we were actually able to translate that into a series of I would call them more frontline or top-line results. And so, as we move to slide 24, you'll see when we actually sat down and put pen to paper around some of these joint ventures and purchasing into these joint ventures to build this network, we found there was an opportunity where if the hospital were able to buy in at a slightly higher share purchase percentage, the ability for that system to leverage its managed care rate structure and its affiliate language for its managed care rates actually provided a fairly sizable accretive value to several of these ASCs. And so what we have here on slide 24 just shows that just by kind of bringing the hospital into in as a partner for this ASC, we're able to actually generate about an additional $3 million in revenue for that ASC, which, you know, if the physicians the physicians owned 100%, they actually ended up selling 70% to the system, and they were able to increase their dividends and their distributions by almost $1 million. So again, it became a very accretive scenario for both the hospital or the health system as well as the physician organization to bring the system in, which is really interesting when we think about the ways in which a health system can provide value to an ASC as a partner. And so what I'd like to do right now, which really gets into kind of what does this all mean? I mean, these are great examples, but what does it all mean? And so, we call this kind of the wheel of fortune on slide 26, but you can see there's actually a lot of value that a hospital and a health system can bring to an ASC. So as we start to talk to, with our migration plan in hand and with the various tracks that we want to go down to help with that, help overcome kind of that migration, the migration components that we've identified. It's important that we have a cogent story around how can a hospital or health system kind of bring value to an ASC. And really, again, this wheel of fortune or wheel of services helps identify all the different areas that a hospital or health system can actually provide significant value to current ASC owners. So everything from purchasing biomedical equipment, medical staff credentialing, group purchasing agreements, accounting and finance support, biohazardous safety and waste, right? All the plant, the facilities, the maintenance, managed care contracting, which we talked about, capital equipment, HR, laundry, linen, IT services. Bringing a hospital in or a hospital taking an equity position in an ASC, right? Obviously, it presents an opportunity for the orderly surgery and migration, but it also allows us to deliver these services to an ASC at very competitive rates, right? Obviously, they have to be fair market value, but it is possible to leverage the size and scope of a hospital and a health network to really bring some really nice pricing from an expense management perspective into the ASC. At the same point in time, when we talk about the managed care contracting rate, obviously we get back into those bundle payments and payment innovation. And so, again, being able to decant some of our expensive surgeries into a lower cost setting from a bundle payment perspective provides an economic opportunity for the parties who are participating in that bundle payment component, right? It obviously also allows us to open up new access points and kind of bringing that capital equipment and the plant and facility to bear helps that. And then finally, obviously, the story works really well with physicians as we talk about, how do we align without actually employing physicians. And so being able to continue down the road of a community-based physician organization, a community-based physician world, while still being aligned with the hospital health system is a pretty important component. So I think, right, which really gets back to, okay, so we can provide all these services, and on slide 27, right, again, this just gets back to how do we provide those services? Do we provide them through just management support? Do we provide them through an entire ASC division? Or do we say, well, actually the best prices are actually through a third-party ASC management company? And, I think we've found that we spend a lot of time with organizations talking about how do we want to think about managing our organization long term? And are we looking, is building or purchasing, converting an ASC, is it a one-off? Or are we thinking that there's 4, 5, 6 ASCs that will be a part of our service offering in 5 or 10 years? And that really helps to drive where do we want to go as far as building or buying the infrastructure to do this. I mean, hospitals and health systems have a great ability to leverage their infrastructure, and being able to bring that to bear to an ASC or a series of ASCs is again, pretty powerful from a story perspective, which really all ties back to, on slide 28, how do we thread the needle of success, right? With all the changes that are going on as we talk about surgery migration and cannibalization, how do we think about our system-wide OR capacity? Do we convert, right? Do we convert ORs? Do we build new ORs? Do we purchase into ASCs, existing ASCs? Right, at the same point in time, with the migration and cannibalization and the OR system, OR capacity, do we have our ORs in the right locations, right? Do we need to think about moving out into more primary and secondary service markets? So what are our geographic strategies, and how do we think about those from a factor perspective? Obviously, we talked about the physician alignment piece and the alternative payment methods, but making sure that physicians understand the alternative payment methods and how what they're doing and how what we're doing affects and kind of improves the overall economics is important. And obviously, we're going to continue to see more pricing transparency requirements, and so our ability to kind of show the price and show what that looks like before having the surgery is going to be pretty important. As Naya mentioned earlier in the presentation, payers continue to redesign and refine their benefit designs in such a manner where hospitals and health systems really need to continue to kind of move into this ASC space, and that's really a critical factor in kind of their considerations. And then finally, just the equity structure and the financial returns, right? If we can again take advantage of the hospital's purchasing power, the hospital's managed care contracts, other things the hospital has from a management services perspective, that can change the equity structure and obviously the financial return, because at the end of the day, right, we want access points, we want efficiency within our ASCs, and we want to be able to continue to change the cost curve and kind of move the financial returns in such a manner where everyone's happy and continues to want to build these ASCs in this space. And so what I'd like to do right now is just turn the presentation over to Matt, who I think has gotten a bunch of questions from the audience.
Thank you, Sean. Yes, so before we move on to some of your questions, a reminder to the audience to please continue entering any questions you have in the questions pane, and we'll answer as many of those as time permits. So first question, Naya, this one's going to come to you. And this question has to do with revenue cycle. In terms of optimizing revenue cycle, if a health system or hospital is engaged with an ASC, do you recommend that revenue cycle be done in-house, or thoughts on pros or cons of outsourcing to an outside third-party vendor?
In a hospital ASC JV, it really just depends. If you outsource to a third-party billing company, they are going to typically charge you and can be a fairly steep billing service fee. And so if that billing service fee, is 4, 5, 6% of your revenue versus identifying an internal ASC-specific business office team with the expertise in ASC billing and collections, you typically will save from the standpoint of your employees. However, it's absolutely important that you are able to find people with that ASC expertise, because it is different. If you do not have access to that, then it may be advantageous to seek out a third-party billing company for your rev cycle.
So you're saying like the billing and coding at the ASC level might look different than it does at the historical HOPD or hospital side?
It absolutely will be different. So the ASC payment systems, the ASC contractual arrangements and so forth that impact collections and billing are different. However, the expertise inside of a health system is typically going to be very robust, especially with certified coders and things like that. But if you maintain it and the hospital were to provide that service, it would be important that they had designated staff to support the ASC.
Okay, great. Thank you. Sean, next question's for you, and it has to do with fair market value. How is fair market value determined for services provided to an ASC as outlined on slide 26, the one we just saw? And can fair market value be determined using an IRS transfer pricing rule?
Well, what we've seen and what we've helped organizations do, I think building off of Naya's point from the last question, there's a couple of different ways, right? I mean, there's definitely a build-up approach where, again, if we're identifying individual staff who's going to do the work, we can kind of plus and minus to come up with an overall rate. I think there's also kind of a series of publicly available data sources that identify at least as a percent of revenue or a per record amount that we also like to use around that. And as far as the IRS transfer pricing, I'd have to research that a little bit more, but I would think that if that is kind of a standard out there in the industry, I think there's probably a way to leverage that. I think we would just need to make sure that, again, from a fair market value perspective, we are really not undercharging the ASC for those services due to the fact that we don't want to get into any Stark law violations or any anti-kickback statutes.
Okay, great, thank you. We've got a couple questions now related to the academic medical centers. I'm going to kind of blend them into one question. One of them is, we're an academic medical center, so how does this affect us? And the other looks at the question about what are strategies that you all have seen to engage employed academic medical center faculty, clinically employed faculty, to participate in this shifting cases to ventures that they may or may not be participants in terms of the revenue?
This is Naya. I can take an opportunity here to comment on some of this, and then I'll flip over to Sean. With respect to academic medical centers, it's a great question because it's become an increasingly important factor of physician education and training. Unfortunately, ASCs do not have academic status that provides them the opportunity for rate differential for teaching status. So when academic medical centers are looking to incorporate an ASC into their faculty practice or their training in medical education, some of the key observations we have seen with those that are starting to go down this path is making sure that the rotations in an ASC are more advanced, like in a third-year fellowship, third-year fellow, for example. It is definitely on the radar screen of the National Association ASCA. I sit on the Government Affairs Committee, and we have discussed this in the past at that level about academic teaching status of ASCs and whether or not that should be presented to CMS, as an opportunity for academic medical centers. So I think there's definitely some discussion there. With respect to employed physicians working in academic medical centers and working at ASCs, we have absolutely seen some academic facilities offer the opportunity for employed physicians to work, in the surgery centers, whether or not they are allowed to participate economically is subject, obviously, from a regulatory standpoint. But there's different ways where you can structure potential physician compensation and so forth associated with that. And at that point, I'll switch it over to Sean to see if you want to weigh in on some of that.
Yeah, thanks, Naya. Yeah, I think some of it depends on, for employed physicians, regardless of whether they're academic or community-based, it depends on the compensation plan. And if there is a productivity component in their compensation plan and they can use an ambulatory surgery center and effectively do more cases in the same amount of time as they would on campus, right? I mean, I think that would be very beneficial and accretive to their overall compensation and their exposure to new techniques and new ways of working. And I think that also extends into when you look at the kind of the attendings and the residents. And I think, as Naya, you mentioned, right, as we get into some of the later stage residencies, moving and having that ambulatory framework, regardless of whether or not there's a differential. I think that, as we get in there, I think we're seeing more and more organizations want to introduce an ASC component so that newly minted physicians don't walk out into the world and now they start hearing about ASCs. They have some experience and some exposure to that kind of during their training later in their residency.
Thank you, Sean. So we have time for one more quick question, Naya. This is going to come to you, and it's, are Medicare Advantage payers restricted to the same criteria in approving procedures that can be performed in a freestanding surgery center as traditional Medicare? So I think the answer for this one, what we have seen is most payers do have to follow Medicare, but they have some flexibility. We've seen payers that will take a case that is traditionally performed on commercial age individuals and enable it to be added to a Medicare list, but for the most part, it's still pretty much following that Medicare approved list. So we didn't get to answer one of your questions. We will get back to you directly. And if you have any other questions or comments, please don't hesitate to contact us via the contact information provided in the handout. Thank you again, Sean and Naya, for your time and information and answers to these questions. And then one final reminder, we would greatly appreciate it if you could take a moment, audience, to complete the electronic survey upon exiting today's program. Again, as we mentioned, ECG will make a $5 donation for every survey completed to the Doctors Without Borders program. Thank you again, everyone, for attending today's webinar, and we hope you have an enjoyable rest of your day. Bye now.